In MRCP, acute coronary syndrome is not about memorizing drug lists. It is about recognizing risk, interpreting the ECG correctly, and choosing the right management pathway at the right time. In this video, I will give you a clear, exam-focused approach to acute coronary syndrome, covering definitions, ECG interpretation, investigations, and management logic exactly as MRCP expects. Acute coronary syndrome refers to a spectrum of clinical conditions caused by reduced coronary blood flow, leading to myocardial ischemia or infarction. There are three types: ST elevation myocardial infarction, where there is full thickness myocardial injury and ST elevation on the ECG. Non-ST elevation myocardial infarction, where there is subendocardial infarction with raised troponin but no ST elevation. And unstable angina, where there is myocardial ischemia without troponin elevation. The underlying mechanism is atherosclerosis. Endothelial injury allows LDL to enter the intima and become oxidized. Macrophages ingest oxidized LDL to form foam cells, which is the earliest visible lesion. Smooth muscle migration and collagen deposition form a fibrous cap. When this cap ruptures, thrombogenic material is exposed, leading to platelet activation, thrombus formation, and acute coronary syndrome. This explains why macrophages are the key cell involved in plaque development, a direct MRCP favorite. Hypertension is the most common risk factor, but diabetes mellitus is the most serious. Diabetic patients may develop silent myocardial infarction due to autonomic dysfunction. Other important factors include smoking, dyslipidemia, chronic kidney disease, and post-operative status, with the highest risk occurring around 72 hours after surgery. Typical chest pain is heavy, tight, or pressure-like, often radiating to the left arm, jaw, or back, lasting more than 15 to 20 minutes, and not relieved by rest or GTN. Associated symptoms include sweating, nausea, breathlessness, and syncope. Emotional stress and surgery can precipitate demand ischemia, especially in type 2 myocardial infarction. The ECG is the most important initial investigation and must be performed immediately. However, a normal ECG does not exclude myocardial infarction. Troponin should be measured at presentation and repeated after 1 to 3 hours using high-sensitivity assays. Echocardiography is useful when the diagnosis is uncertain or to assess left ventricular function. Coronary angiography is the definitive diagnostic test. Hyperacute T waves are often the earliest ECG change in ischemia and may precede ST elevation. This has been tested directly in MRCP. ST elevation in leads 2, 3, and a VF indicates an inferior myocardial infarction, usually due to right coronary artery occlusion. Anterior infarction involves the left anterior descending artery, and posterior infarction presents with ST depression in V1 to V3 with tall R waves. All patients should receive aspirin 300 mg immediately, unless contraindicated. Oxygen is only given if SpO2 is below 94%. Nitrates are used for pain or hypertension, but must be avoided in hypotension. Morphine should be reserved for severe pain and not used routinely. Poor prognostic features include older age, hypotension, renal impairment, raised troponin, ST segment deviation, and a high Killip class. Remember that Killip class predicts mortality in acute myocardial infarction. STEMI requires immediate reperfusion. Primary PCI is preferred if it can be delivered within 120 minutes of diagnosis. If PCI is not available within this time frame, thrombolysis should be given within 12 hours of symptom onset. After thrombolysis, repeat the ECG at 90 minutes. Failure of ST resolution requires rescue PCI. All NSTEMI and unstable angina patients receive aspirin and fondaparinux unless immediate PCI is planned. They are then risk stratified using the GRACE score. Low-risk patients are managed conservatively. High-risk or unstable patients require early angiography, immediately if unstable, or within 72 hours if stable. Unstable angina differs from NSTEMI by normal serial troponin levels. Prinzmetal angina is due to coronary vasospasm, causes transient ST elevation, responds rapidly to nitrates, and if treated with calcium channel blockers, not beta blockers. Drug-eluting stents require dual antiplatelet therapy for 12 months. Premature withdrawal of antiplatelet therapy is the most common cause of stent thrombosis. Elective surgery should be delayed for 12 months after drug-eluting stent insertion. Ventricular arrhythmias occur early. Papillary muscle rupture occurs 2 to 7 days post-MI. Ventricular free wall rupture typically occurs between 5 and 14 days and causes cardiac tamponade. Dressler syndrome is a late autoimmune pericarditis occurring weeks after.
Now let us move to MRCP-style questions. These are short clinical scenarios designed to test decision-making rather than recall. Listen carefully to the timing, the ECG, and the available facilities, because in MRCP, the correct answer depends on context. Let us start.
A 55-year-old man presents with crushing central chest pain that started 30 minutes ago. His ECG shows ST elevation in the anterior leads. He has been treated as STEMI with aspirin, clopidogrel, low molecular weight heparin, GTN, and morphine. There is no cath lab on site, and the nearest PCI center is 2.5 hours away. What is the most appropriate next step?
Give fibrinolysis with alteplase.
Why is fibrinolysis indicated in this situation? Why is transfer to the PCI center alone not the best immediate option? What must be done after fibrinolysis? What finding would indicate failed thrombolysis? Why is bivalirudin not appropriate at this stage? And why is unfractionated heparin infusion with transfer not the best answer here?
This patient has a STEMI within 12 hours of symptom onset, and primary PCI cannot be delivered within 120 minutes. So fibrinolysis should be given promptly, using alteplase or tenecteplase. Transfer alone is not appropriate, because reperfusion should not be delayed when timely PCI is unavailable. After fibrinolysis, a repeat ECG must be performed at 90 minutes. Failure is defined as less than 50% resolution of ST elevation, in which case urgent transfer for rescue PCI is required. Bivalirudin is not indicated because it is used during PCI, and anticoagulation alone, such as unfractionated heparin with transfer, does not restore coronary perfusion in delayed PCI STEMI.
A 65-year-old man is admitted with chest pain and ECG changes. Troponin T taken 12 hours later confirms an acute myocardial infarction. Which factors predict a poor prognosis?
Poor prognosis in acute coronary syndrome is best predicted using the GRACE score. Adverse factors include increasing age, particularly over 65 years, low systolic blood pressure, renal impairment with raised creatinine, ST segment deviation, elevated cardiac biomarkers, cardiac arrest on admission, and peripheral vascular disease. Heart failure is a key determinant and is assessed using the Killip classification. Killip Class 1 indicates no heart failure. Killip Class 2 indicates mild heart failure, such as basal crepitations or an S3 gallop, and this is where prognosis begins to worsen. Killip Class 3 represents pulmonary edema. Killip Class 4 represents cardiogenic shock and carries the highest mortality.
A 61-year-old man presents with central chest pain. His ECG shows ST depression in the inferior leads, and the pain requires intravenous morphine. He has a history of a thrombolized myocardial infarction 2 years ago, asthma, and type 2 diabetes. He is treated with aspirin, clopidogrel, and unfractionated heparin. Which factor determines whether an intravenous glycoprotein 2B/3A receptor antagonist should be given?
The decision to give an intravenous glycoprotein 2B/3A receptor antagonist depends on two factors: a high GRACE risk score and whether percutaneous coronary intervention is planned. Management of NSTEMI is guided by risk stratification using the GRACE score. According to NICE guidelines, a GRACE score greater than 3% defines intermediate to high risk and indicates an invasive strategy. Coronary angiography with possible PCI should be performed immediately if the patient is clinically unstable, or within 72 hours if the patient is stable. Low-risk patients with a GRACE score of 3% or less are managed conservatively with optimal medical therapy. Intravenous glycoprotein 2B/3A inhibitors are antiplatelet drugs used mainly during high-risk PCI and include abciximab, eptifibatide, and tirofiban. They are considered only in high-risk NSTEMI patients when PCI is planned, not based on GRACE score alone. MRCP takeaway. GRACE greater than 3% require invasive strategy. A stable patient with GRACE greater than 3% needs angiography plus or minus PCI within 72 hours. Unstable patients require immediate angiography. GP 2B/3A inhibitors are indicated only if high-risk PCI is planned.
A 51-year-old man presents with central chest pain radiating to the jaw and arm, associated with nausea and sweating. His ECG shows biphasic T waves in leads V2 to V3. What is the most likely explanation?
Biphasic or deeply inverted T waves in leads V2 to V3 in the context of acute coronary syndrome are characteristic of Wellens syndrome, which reflects critical proximal left anterior descending artery stenosis. These ECG changes often occur when the patient is pain-free and indicate a high risk of imminent anterior myocardial infarction due to sudden LAD occlusion. Patients require urgent coronary angiography and revascularization, and stress testing is contraindicated.